This slide, I put the outline of the lecture in the middle. I'll start with case presentations, the epidemiology, etiology, pathogenesis, the clinical symptoms, how to diagnose the disease, the treatment, preventive measures, and to take home messages. And on each side, on one side, I put the similarities between these diseases, and the other side, the differences. And we'll go into detail as we go on. Enteric fever is a severe systemic infection caused by Salmonella enterica serovar typhi, S. typhi, and Salmonella enterica serovar paratyphi is a common cause of morbidity in the developing countries, including Lebanon. I will start with two case presentations. First one is Mr. Rodriguez, who is a 30-year-old teacher who returned to the USA from a 3-month volunteering trip to a refugee camp in the Middle East. Since his return, he has been feeling progressively fatigued, with increasing weakness and unremitting fever that seems to peak every afternoon. He mentions an increasing distaste for food, abdominal discomfort, and constipation. His family also noticed a dull, somewhat blank expression on his face recently. CBC showed an elevated white blood count with relative lymphocytosis and mildly elevated transaminases. Given his travel history, typhoid fever is suspected. The second case is about Miss YD, a 50-year-old woman with no significant past medical history, presents to the emergency department because of high-grade fever for the past 3 weeks. She admitted consuming homemade cheese and ice cream and eating salads in local restaurants. The fever was associated with increasing abdominal pain and altered bowel movements. Over the past few days, she had noticed increasing abdominal distension and intense pain. On physical exam, she appears acutely ill and has signs of peritonitis. A CT scan of her abdomen reveals free air and fluid in the abdomen, consistent with perforated viscus. She's taken to the emergency room, to the operating room for exploratory laparotomy, and cultures of peritoneal fluid grew Salmonella typhi. Typhoid fever is a systemic infection caused by the bacterium Salmonella typhi, which primarily spreads through contaminated food and water. So it's mainly if we eat or drink something contaminated with Salmonella. And it affects a large number of people in the world, in millions. Yani about 20 millions annually are affected, and with a significant number of deaths, up to 161,000 deaths per year. It is declining in the developed countries, but it is still a major problem in the developing countries. Lebanon falls in the WHO medium incidence area with 600 to 900 cases of typhoid fever being reported yearly to the Ministry of Public Health, and this number may not represent the actual number of cases occurring in Lebanon. Salmonella are aerobic, motile, gram-negative bacilli, and we divide them in two categories. One, salmonella that are human restricted. They affect only human. And these are Salmonella enterica serotype typhi, which cause typhoid fever. Salmonella paratyphi A, paratyphi B, and paratyphi C, which cause also a disease similar to typhoid fever, and it is called also enteric fever. The other type of salmonella can affect human and animals. Similarly, Salmonella cholerae suis is one which causes bacteremia, and non-typhoidal salmonella, which are the most common cause of gastroenteritis. Typhoid fever is mainly transmitted via fecal-oral route. Yani one doesn't have to eat directly feces or stools, but minor contamination of food or water with feces will be infectious and will cause disease. Sexual transmission is also possible depending on the type of sexual activity that is performed. People working in the lab for culturing stools and other materials will be exposed more than others. Also, people taking care of sick persons with typhoid fever are more likely to be exposed and to get the disease. Mind you that the infectious dose of typhoid fever is very low. Even in healthy volunteer, a dose of less than 1,000 organisms can cause disease. There are some factors that will increase the chances of acquiring typhoid fever, and they are also listed on the slide. One is lack of access to drinking water and ice that is clean, not contaminated, and lack of access to toilet facility. Lack of hand washing is very obvious, and it helps in this disease and other diseases. Use of sewage as fertilizers will increase the chances of contamination with typhoid fever. Flooding will mix water and sewage, and of course, it will increase the risk of transmission. In persons with reduced gastric acidity from any cause are at higher risk of acquiring the disease if exposed to it, meaning living in crowded urban areas, like any other disease, will be more likely to be transmitted in this setting. The pathogenesis of typhoid fever is listed on the slide, is shown on this slide. We start by ingestion of Salmonella typhi organism. If they survive the passage through the gastric acidity, they reach the small intestine where they multiply, and they penetrate through the mucosa, causing only minimal epithelial damage. They reach the intestinal lymphatics, and through the thoracic duct, they go to the bloodstream. From the bloodstream, they are distributed everywhere, including the spleen, liver, reticuloendothelial system. And they'll have intracellular multiplication of the Salmonella typhi, and then they re-enter the blood, and they re-enter the intestine through the bile. Clinical course of enteric fever is variable. Let's start with the incubation period, which ranges between 10 to 14 days. The classical presentation of typhoid fever is like this. It will start with a rising temperature over around a week to reach a peak, and then this peak is maintained until the patient is treated, or it continues for up to 6 weeks and end by defervescence or death of the patient without antibiotic therapy. This is classical, but nowadays we don't see this classical presentation. The fever may be variable, and from benign febrile illness to toxemia, and with associated complications like intestinal perforations and sepsis. Severe disease occur in about 10 to 15% of the cases. It is noted that many cases of typhoid fever will relapse witut reinfection about 2 to 3 weeks after completion of treatment. It is also noted that there is a carriage state in stools and urine in about 5% of the cases. Mortality in the antibiotic era is very low, less than 1%. And if managed quickly, it shouldn't be a problem. The symptoms and signs of enteric fever are very variable. Of course, fever, chills, and dull headache occurs in almost everybody. You can notice a dry cough, sweating, myalgia, malaise, arthralgia, anorexia, abdominal pain, nausea, vomiting. Constipation, which is thought to be one of the major symptoms of typhoid fever, occur mainly in adults. In children, they may have diarrhea instead of complication. And if noted, there is a blank expression on the face, like a poker face, of patient with typhoid fever. On physical exam, you can notice a relative bradycardia, which can occur also in other diseases. Abdominal tenderness, which is nonspecific. Splenomegaly, hepatomegaly can occur in many diseases. Rose spots may be seen but are very rare. The tongue may be coated, and occasionally epistaxis may occur. On this slide, I tried to show the macular rash of typhoid fever. It is a 2.2 to 4 millimeter in diameter, raised, discrete, pink, and blanching on pressure. It is found mainly on the front of the chest. It appears in the crops and fades after 3 to 4 days. Although it is reported or mentioned in the clinical finding in typhoid fever, it is very rarely noticed. Typhoid fever is suspected on the basis of travel history or living in a geographic area where typhoid fever is endemic. Also, the living conditions, if it's living in a poor poor living conditions without access of water to clean water or toilet facility, uh, makes it a likely possibility. And the clinical findings, as mentioned before, also point towards typhoid fever. As I mentioned earlier, and you cannot make the diagnosis solely on typhoid on the clinical finding because they overlap with other diseases. To confirm the diagnosis of typhoid fever, we need to recover it from culture. Usually, we do blood culture, stool culture. Less commonly, we resort to bone marrow aspect for culture. And intestinal secretion is very rarely, if ever, done to make the diagnosis of typhoid fever in the clinical setting. Serological tests, while Vidal test was widely used, but it dropped from use now because it is inaccurate and it takes two samples to prove the diagnosis. And mind you that typhoid fever is more common in underdeveloped countries or developing countries. So methods like ELISA, PCR, DNA probe are not very practical to make the diagnosis. Once the diagnosis of typhoid fever is confirmed, or the treating physician decides to treat empirically for typhoid fever because of high suspicion, the only treatment is antibiotic therapy. Over the years, Salmonella have acquired resistance to many antibiotics. But the current treatment of choice is ceftriaxone, ciprofloxacin, or azithromycin. Even we noted the resistance of some Salmonella strain to these antibiotics. So it is warranted to isolate the organism and to do susceptibility testing. Sometimes typhoid fever may be complicated with severe types of complication that either require admission to intensive care unit or that necessitate surgical intervention, mainly if there is perforation of the intestine. The other complication of typhoid fever is chronic carrier state. And this will lead to persistence of typhoid fever in a population. So the chronic carriers will spread the disease to others. And you have noticed that in history, Typhoid Mary caused many outbreaks of typhoid fever in New York in the past century. Management of this chronic carrier state would require prolonged courses of antibiotics or even cholecystectomy. When we talk about typhoid fever, we should also talk about vaccination. Vaccinations is recommended to people living in a non-endemic area when they go to visit an endemic area, or to persons with intimate exposure to patients with typhoid fever, or to patients or persons with potential occupational exposures. In endemic area, the WHO in the last few years approved a typhoid conjugate vaccine for children more than 6 months and less than 15 years. About vaccination, what I want you to remember is that the protective efficacy of the typhoid vaccine is not like the protective efficacy of viral vaccines. It fades shortly, few years, depending on the type of vaccine. And the protective efficacy can be overcome by a high dose. So if we said less than 1,000 organism can cause disease, maybe the typhoid vaccine will prevent this. But if the dose is 10 times more or 20 times more, it cannot be prevented by vaccination. So even for vaccinated people, they should always practice good hygiene and avoid using high-risk beverages and foods. Prevention and control of typhoid fever should be theoretically feasible, since S. typhi is a human-restricted pathogen, so it can be controlled by hand washing, proper sewage disposal, water treatment, and monitoring of food and water supply, and vaccination. However, it is easily said than done. Maybe it has been achieved in highly developed countries, but this problem remains very active in uh, developing countries. In conclusion, typhoid fever remains a significant global health issue, particularly in resource-limited settings. The second point is that Salmonella acquired resistance to many antibiotics over the years. So we have to look into this and to prevent the abuse of antibiotics. Early diagnosis, appropriate treatment, and concerted public health efforts are vital to controlling the disease. Our role extends beyond patient care to include education and advocacy for improved public health measures and appropriate use of antibiotics in humans and in animals. Brucellosis is a human disease acquired from animals, a zoonosis. The main species affecting humans is Brucella melitensis. Brucellosis has been known with many names, such as Malta fever, Andulant fever, Mediterranean fever, rock fever of Gibraltar, gastric fever, and others. To start the discussion of brucellosis, we'll present two cases. A 40-year-old farmer presents with a 2-week history of intermittent fever, night sweats, and joint pains. Blood tests reveal elevated inflammatory markers, and serology confirm a diagnosis of Brucella melitensis infection. The second case is a 55-year-old male shepherd presents with back pain, fever, and weight loss. Imaging shows spondylodiscitis, and blood cultures eventually grew brucella. The patient is diagnosed with chronic brucellosis with osteoarticular. Brucellosis is the most common bacterial zoonosis with 1.6 to 2.1 million new cases reported annually. It is estimated that 3.5 billion people are at risk of acquiring brucellosis. In Lebanon, 250 to 500 cases are reported every year to the Ministry of Public Health, compared to 100 to 200 cases per year in the USA, taking into consideration the difference in the number of population. Brucellosis has worldwide distribution. The Mediterranean area is an endemic area for brucellosis. It is noted the seasonal variation with mainly in the spring area Springtime incidence is higher than other times of the year, and manifestations are variable. It can be an acute, follows an acute course, subacute, or chronic course. The population at risk for acquiring brucellosis are people taking care of animals like cattle ranchers, dairy farmers, veterinarian, abattoir workers, meat inspectors, lab workers in the microbiology lab. Hunters are exposed, travelers, and most commonly consumers of unpasteurized dairy products. The transmission is mainly by ingestion. Ingesting raw dairy products like colostrum, raw milk, unpasteurized cheeses, undercooked raw meat. Human-to-human transmission is reported mainly via blood or blood products, bone marrow transplantation, or tissue transplantation. Sexual transmission is only lacks evidence. Breastfeeding may transmit the disease, and in healthcare workers, mainly in the working in the lab, it can be transmitted via mucous membrane or ablated skin, or a laboratory accident via aerosol or inhalation. And last is accidental injection of animal vaccines while to the human. Brucella, gram-negative coccobacillus, the small, non-motile, non-spore forming, and facultative intracellular organism. One of the main quality is environmental persistence in dust, soil, water, fetuses, and other products. And it is very tough to kill. It withstands drying, humidity, and freezing. Multiple species, which are host-specific, are identified. Brucella abortus in cattle, Brucella canis in dogs, Brucella melitensis in goats and sheep, cow and camels, and this is the most common species that affects humans. Brucella suis affects pigs, horses, reindeer, and hares, and many other species. This is a schematic representation of pathogenesis of Brucella and host immune response. The first point is the entry of the brucella into the macrophage by phagocytosis, and presentation of the brucella antigen. The brucella antigen, in one way, it will stimulate the T lymphocytes to produce interferon gamma. Interferon gamma will act on the natural killer cells, and it will act on the T lymphocytes to induce their activity against brucella. As a checking point, there is inhibition of TNF alpha production that will limit the activity of the natural killer cells. Then brucella are released from the macrophage they are incompletely killed, and they will infect other cells. The production of antibodies is not helpful in controlling the disease. It is rather used for diagnosis of brucellosis. On this slide, I'm listing the brucella survival strategy. Brucella is a stealth pathogen. It does not confront directly. It sneaks in. So it avoids triggering innate immune response. It permits survival within the monocytic cells, and it produces a mild but prolonged inflammatory process. It has a non-classical lipopolysaccharide with low toxicity and pyrogenicity, and it is a weak inducer of interferons and tumor necrosis factor. Tissue damage is secondary to activation of the host immune response and the granuloma formation. The incubation Period of brucellosis is variable from 5 to 21 days up to several months. It involves many systems, any organ in the body or organ system. It causes a cyclic type of fever. Focal infection is noted in 30% of the cases. It starts with a flu-like illness, may wax and wane, and may proceed to become a chronic illness. On this side, this is the human body, and I listed all the organs that are affected. As you can see from the slide, everything can be affected. Most commonly affected is the skeletal system. But however, the GI, the heart, the lungs, the meninges, the brain, all are affected. So it is a multi-system involvement, and one organ may be involved more than others. But the most common involved organ is the skeletal system. This is a retrospective study from 19 health institutions in Turkey, and looking at spinal brucellosis. And as you can see from the slide, most commonly the lumbar area is affected, and mainly L4, L5 is the most common site of affection. As a pregnant mother have brucellosis, the offspring may be affected with congenital brucellosis. Some of the affected infants are delivered prematurely, while others are born at full term. Common symptoms include low birth weight, fever, fatigue, failure to thrive, jaundice, hepatomegaly, and splenomegaly. Some newborn with congenital brucellosis have respiratory difficulty or severe respiratory distress, hypotension, vomiting, and other signs of sepsis. And other infants may be asymptomatic or have only mild symptoms. The diagnosis of brucellosis relies mostly on serological testing. The serum agglutination test, or SAT, by tube dilution is the cornerstone of serodiagnosis. Also, we can use an indirect Coombs antihuman globulin test by tube dilution to detect incomplete or blocking or non-agglutinating immunoglobulins. There are also ELISA and immunofluorescent and PCR and many other tests are used, but most commonly serum agglutination test is the main diagnostic tool for brucellosis. Cultures, brucella may be recovered from culture, but the rate of recovery is not that high. It takes about 10 to 14 days in acute cases, and the yield is higher in acute cases rather than chronic cases. Concentration and lysis of the buffy coat before culture may increase the yield. Sometimes we resort to bone marrow culture, which gives a higher yield than blood. And if you have a specific organ that is involved, a tissue culture may grow brucellosis. Treatment of brucellosis is antibiotic therapy. We have many antibiotics that are active against brucellosis, and mainly we are talking about doxycycline, rifampicin, aminoglycoside like streptomycin or gentamicin, trimethoprim sulfamethoxazole, and ceftriaxone. The point is, we cannot treat brucellosis with a single antibiotic. We have to use a combination of antibiotic in almost all cases. So it is a combination antibiotic. The usual combination is doxycycline plus rifampicin. And in severe cases, aminoglycoside is added for initial week or so, and then treatment is continued by doxycycline and rifampicin. In case the meninges are involved, a course of ceftriaxone intravenously will be added to the treatment plan. And the duration of therapy is prolonged. Most commonly, 6 weeks treatment is advocated, sometimes longer treatment, especially if there is a proof of bony involvement. We may go up to 3 months or 6 months. And in terms of meningitis or endocarditis, the treatment may be longer. Brucellosis is rarely fatal if treated. In untreated persons, estimates of the case fatality rate vary from less than 2% to 5%. As we said, antibiotics are usually the mainstay of treatment. Long-term treatment may be required. Some form of localized disease, such as endocarditis, may require surgery, valve replacement. Deaths are usually caused by endocarditis or meningitis. Although recovery is common, disability is often pronounced depending on the localization of infection and the response to treatment. Approximately 5% of treated cases will relapse weeks to months after therapy has ended due to the failure to complete the treatment regimen or infection that requires surgical drainage. Antibiotic-resistant strains of Brucella have been reported, but the clinical importance of the fact is not well understood. Brucellosis is a zoonosis, which means a disease acquired from animals. So the first step to controlling or preventing brucellosis is to eliminate brucellosis from livestock. And this is done by vaccination of the livestock or by slaughtering. And controlling and monitoring occupational and food hygiene is a major issue. Making sure to prepare all dairy products from heat-treated milk. Avoid consumption of raw dairy products. Cook meat adequately. Take special precautions in diagnostic laboratories and public education. The most difficult part is convincing people not to consume raw milk and raw dairy products and not to eat raw meat. This will require a lot of education. The take-home messages for this part is brucellosis is a significant zoonotic disease with a global distribution. It has non-specific symptomatology and multiple presentations. Every organ system is involved. Early diagnosis and appropriate treatment are crucial to prevent complications. Prevention through animal vaccination, food safety measures, and protective measures for at-risk individuals is essential for control. Urine typhus or endemic typhus is usually a benign illness characterized by fever, headache, and macular or maculopapular rash. Start by presenting two cases. Patient 1, Miss Sofia, a 35-year-old woman recently returned from a hiking trip in Southeast Asia. She noted rodent activity where she stayed. Presentation, she presented with acute onset of fever, severe headache, generalized muscle pain, and a faint rash on her trunk. Endemic typhus is suspected due to her travel history and symptoms. Empirical treatment with doxycycline is initiated before confirmation through serological testing. Patient number 2 is Mr. Ahmad, who is a 55-year-old homeless man living in urban slum condition. He presented with high fever, severe headache, disorientation, a widespread rash, and signs of meningeal irritation. Endemic typhus is suspected due to living conditions and symptoms. Empirical treatment with doxycycline is initiated before confirmation through serology and CSF analysis. Urine typhus, also known as endemic typhus, is a flea-borne disease with a worldwide distribution and is caused by Rickettsia typhi. Urine typhus is primarily transmitted by the rat flea, Xenopsilla chiopis. The incidence is difficult to establish since the disease can be mild, self-limited, and clinically like other causes of rash and fever. Urine typhus sporadically occurs on all the inhabited continents, in environments ranging from hot to cold and from humid to arid. There is no seasonal variation in urine typhus in tropical area, but in temperate regions, the disease is most common in hot, dry periods such as late summer and early fall. It is not contagious from man to man. Rickettsia typhi is a gram-negative bacteria. It is an obligate intracellular bacteria, non-motile. It looks like a small bacillus or cocci with variable arrangement. Stains by Gimsa, Gastanida, and Machiavello. Culture is only done in special lab because of its high infectivity, and it has the ability to survive outside the reservoir or vector. And again, it is a highly infective, so only in special lab it is cultured. The other diagnosis is serological. Slide, I listed the vectors of Rickettsia typhi and the mammalian host. The vector most common is the flea, Xenopsilla chiopis, and others. And the mammalian host is mainly the rat, the house mice, the cats. The man is only a bystander in this thing. The flea is permanently infected with Rickettsia typhi, and the lifespan of the flea is not shortened by the presence of the Rickettsia. On this slide, we have the transmission and pathogenesis of Rickettsia typhi. There is two cycles, a suburban cycle and an urban cycle. In urban cycle, the rat is a mammalian host. In the suburban cycle, many other animals are the host. And man is in between. So if a flea bites an infected rat or other animal and then bites a human person, he will get the infection. And human infected by the inoculation of infected flea feces and bite wounds, and the incubation period is 7 to 14 days. It also can be transmitted by aerosol and enters the host bloodstream and invades the endothelial cells. Rickettsia typhi multiply within these cells, causing endothelial cell death and leading to increased vascular permeability. This pathogenic process results in the clinical manifestation of the disease. The incubation period of endemic typhus is 7 to 14 days. It starts with an abrupt onset and usually causes a mild illness with non-specific symptoms. The classical triad of fever, headache, and rash only occurs in about 50% of patients. And additional symptoms are varies from arthralgias, hepatomegaly, splenomegaly, cough, nausea, vomiting, diarrhea, abdominal pain, and confusion. So essentially the same symptoms that are noted in typhoid fever and brucellosis. Laboratory finding, you can see thrombocytopenia. White blood cell count is usually normal. Hyponatremia may be noted with mildly elevated liver function test. CSF abnormalities consistent with aseptic and meningitis are noted if an LP is done. On this slide, I'm trying to show you the endemic typhus rash, which is a faint maculopapular rash, pink colored, and appears after 4 to 5 days of illness and persists for 4 to 8 days. It appears on the trunk and extremities. Although endemic typhus is usually a mild disease, self-limiting, that requires no treatment, sometimes there are cases of severe disease, and it may present with a renal dysfunction, usually pre-renal or interstitial nephritis, may cause pulmonary edema, can have ocular exudates, hemorrhage, vitreal inflammation, mental confusion, and focal neurological symptoms. And In rare cases, multi-organ failure and septic shock. Risk factor for this severe manifestation or severe disease is G6PD deficiency and advanced age. As mentioned earlier, Rickettsia typhi is an obligate intracellular organism that can only be grown in tissue cultures, the cells of experimental animals or chick embryos, and it is done only in specialized laboratories. In the clinical laboratory, we do only serological testing. The first test that was widely used is whale Felix test, which is now dropped from use, and it is only of historical interest. It is non-specific. It uses agglutination of Proteus strains to detect antibodies to Rickettsia typhi, and it lacked sensitivity. Now we can look for specific anti-rickettsia antibody by complement fixation or hemagglutination or indirect fluorescence or latex agglutination or others. Molecular methods include PCR in blood and tissue samples. Endemic typhus is usually a mild disease and self-limiting. Many cases do not come to seek medical care. As you have seen, only a small number of cases, 10, 15 cases, are reported annually to the Lebanese Ministry of Public Health. So, is this truly a self-limited disease versus a chronic or persistent infection? We don't know. But what we know it is a very mild disease, and it resolves without treatment in many cases. It has a low rate of complications. The mortality is less than 1%. And the active antibiotics agents are doxycycline, fluoroquinolones, and chloramphenicol. The last one, which is dropped from use because of its bone marrow toxicity. You expect defervescence in 2 to 4 days, and the duration of treatment is 5 to 7 days. So if the patient comes late to see you, usually you may not treat him. How to prevent endemic typhus? One is rat control, which is impossible, especially in urban areas. Flea control measures on pets, possibly. Trim foliage that harbor rodents, opossum, and stray or feral cats. Put screen on windows. Eliminate food sources for rats and other animals by covering the trash cans. The take-home message for this part is endemic typhus is caused by Rickettsia typhi is a global health issue, especially in regions with poor sanitation and high rodent populations. The clinical presentation is typically include acute onset of fever, headache, and possibly rash. Diagnosis is primarily made via serology. Early treatment with doxycycline is key to prevent severe disease and complications. Control measures focus on vector control and improving living conditions. Thank you for your attention.